Good morning, and thank you all for coming. I'm Nizar Georgiou. I'm the division head for Allergy, Pulmonary, and Critical Care Medicine. And on behalf of Dr. Betsy Trowbridge, our Department of Medicine chair, who couldn't be with us today, I want to welcome you to the Department of Medicine Grand Rounds. It's my distinct pleasure this morning to introduce today's speaker, Dr. Loren Denlinger, a professor of medicine in the Division of Allergy, Pulmonary, and Critical Care Medicine. Loren did his undergrad at the University of Michigan, followed by an MD PhD right here in Wisconsin, which he followed in 1998 by internal medicine residency and pulmonary critical care fellowship at University of Wisconsin. In 2005, we were fortunate enough to recruit Loren to join us as an assistant professor. He has risen through the rank and became a professor of medicine in July of 2019. Loren's research has focused on understanding the mechanism of asthma and how better to treat patients suffering from this disease, especially those with severe asthma. To date, he has published more than 70 papers peer-reviewed in prestigious journals in our field. In recognition of his accomplishment, national stature, and service to the department and to the institution, Dr. Denlinger was selected to be the inaugural recipient of the William and Judy Busee Professorship in Medicine starting this year. Dr. Denlinger's research has continuously been funded since his day one on the faculty by grants from the NIH, starting with a K Award. Right after joining us, and he has continued his illustrious career in publication and funding, with most recently receiving a U Award on the topic of today's grand round, Emerging Endotypes and Precision Medicine in Severe Asthma. Please help me welcome to the podium the William and Judy Busee Professor of Medicine, Dr. Loren Denlinger.
Thank you, Nizar, for that warm introduction, and thank you, Bill and Judy, for this great honor. I had a fantastic time last night, and just like last night, it's hard not to start out by sharing a story with Bill, and I'll give you the short version. With all the mentorship, I now have two little birds that sit on my shoulder. They're both named Bill. One helps me run a meeting, and that bird is very gracious, but also straight no business, is all business. The other one reminds me to tell a story and make sure that there's something for everybody. So hopefully I will live up to that today. So here's my disclosure slide. Nothing commercial in the last 12 months. The most important thing in this slide is I will talk about investigational drugs and a few practices that are off-label. And if you see a text word that's highlighted, that's my buzzword to say this is off-label. It's always good to start out with a case. This patient came from my own clinic, 69-year-old man, no history of asthma, normal childhood. 2 years before I saw him, he started having wheezing episodes and a very classic presentation for asthma symptoms. They were triggered by respiratory viruses and irritants. Primarily, he was out of shape, so the exercise was confusing. The past medical history was pretty routine. He did have some occupational risks with his welding background and secondhand smoke exposure. Not very allergic in terms of the biomarkers. And he had received trials of albuterol, fluticasone, and formoterol, mometasone, for 2 years before seeing me, including seeing one of my partners, and he didn't find them to be very helpful. His first comment to me in opening was, "I just don't think I have asthma." And so I got spirometry, and the first thing to note is he's got pretty good obstruction with a low FEV1 to FVC ratio. He's got lots of bronchodilator reversibility, 19%. And despite that impressive reversibility, his post-FEV1 is still below his lower limit of normal. So he has a COPD-like physiology with bronchodilator responsiveness. So this was very eye-opening to me in the sense that for 2 years, people had been telling him he had asthma, and he just didn't believe it. Pictures can be very helpful, and there's a lot of tools that you can use in your own clinic to help patients understand this. So pictures are worth 1,000 words. This is on HealthLink. You can use that to help with your education. And then most importantly, there's videos online for all inhalers now, which is a big reason why we don't have sample inhalers in our clinic. And there's spacer teaching videos as well. Make sure you watch the patient demonstrate their technique to you, because it's really eye-opening sometimes. It's like, whoa, don't do it that way. So asthma epidemiology, the prevalence still is increasing. Fortunately, the mortality is going down. But the unfortunate part of this is that exacerbations are really unchanged despite this. So the blue line is adults, the black line is children, and about half of all patients with asthma have at least one exacerbation a year requiring systemic corticosteroids. I will tell you there is a new practice that's gaining traction for patients with mild asthma, and that's the concept of using inhaled corticosteroids only at the time that you need a reliever. And so you don't need to use it every day. There's 2 big trials that are shown here. This is supported by, I think, another 5 trials or so. But essentially, to walk you through this, the group that got inhaled corticosteroids twice a day, every day, is the maintenance group here. This is the symptom-driven group, where they only used budesonide and formoterol when they had symptoms, and if they had a good day, they didn't use it at all. And then the rescue reliever, as needed for a mild disease population, is in blue here. And so if you look at asthma control, everyday use of inhaled corticosteroid does have better asthma control, but there's really no difference in exacerbation rate. And the corollary to that is that the patients in the symptom-driven group had a much lower exposure to inhaled corticosteroids. So this has been adopted now by the 2019 GINA guidelines, and I won't walk you through all of the details of this slide. I will point you out to the website here, because you can download these. But the big change is that they are advocating for symptom-driven use of inhaled corticosteroids. They're also suggesting that we have new strategies for the most severe patients, and it's an acknowledgement that oral corticosteroids should really be your last option for maintenance, and even for exacerbations. We're starting to worry that the side effects here are quite high. So a cautionary note for the milder patients with symptom-driven use of inhaled corticosteroids, it's still off-label in the US. It does take some coaching, because the patient will say, well, this is different than all my other doctors told me. What do I do with this? The guideline process in the US is underway. You absolutely cannot use salmeterol for this strategy, because it does not have reliever properties, and it's really just a long-acting partial agonist. If you use more than 4 puffs of formoterol, you can develop side effects like tachycardia. And because it's off-label, you may run into coverage issues from the payer's perspective. So what about the side effects of prednisone? A single burst of prednisone may be a lot riskier than what is commonly recognized. So this is a really pivotal study done in Canada, I believe, with a large data set, complete records. They identified 300,000 cases of patients who got a single steroid burst lasting less than 30 days with a median of just 20 milligrams a day for 6 days. And they had a modified case control design with age matching and comorbidity, and they looked for really bad things, so sepsis, DVT, and fracture. And one burst of corticosteroids has a huge impact. So odds ratios of 3.7, 3.1, 1.96 in the first 30 days after that burst, and that effect lasts for 3 months. Staggering, eye-opening. We use prednisone a lot, but be careful. So I'll transition into severe asthma. is defined by patients who need a very high medication burden, so the highest doses of inhaled corticosteroids plus a second controller. And in addition to that, to qualify for this definition, you have to have evidence of poor control using a standardized symptom survey tool, or increased risk in the form of low lung function or frequent exacerbations. That's a consensus guideline definition. It affects about 10% of adults and children with asthma. In some patients, it mimics COPD with very disabling symptoms and frequent exacerbations that really have a profound impact on quality of life. And it's responsible for at least half of the cost related to asthma care. So it'd be very easy to say, oh, well, Loren can take care of them, or pulmonary or allergy. So this study is a nationwide practice profile to ask the question, who really cares, who provides the care for patients with severe asthma? And generalists take care of two-fold more patients with severe asthma than allergy and pulmonary combined. A slicer dicer survey done by Dr. Jarjur just 2 days ago, there's 1,200 patients in UW Health, and they're not all in my clinic, so. So what can you do if your patient is still symptomatic despite high dose of inhaled corticosteroids plus a long-acting beta-2 agonist? Make sure you've confirmed the diagnosis, especially in patients with adult onset asthma. Make sure you're getting spirometry and bronchodilator reversibility. Spend some time with asthma education. Look for comorbid conditions that are very frequent in this population and treat them, because it may make your asthma symptoms better. So sinusitis, especially if they have nasal polyps. Think about an ENT referral. Reflux, and it's not just pH. Think about secretion management, going to bed early, sleeping upright, Gaviscon for barrier promotion. Vocal cord dysfunction, we've got a great voice clinic here. Seth Daly is the leader of that, and obstructive sleep apnea. Treating those can have a profound impact on severe asthma. You could think of a trial of a long-acting muscarinic antagonist, or possibly use a macrolide, although that's off-label, and there's some risk to that in terms of drug resistance. I will point you again to the GINA guidelines. There is a subset devoted to the workup and care for patients with severe asthma that's very short and practical. 6 years ago, Samir Mather and I opened a multidisciplinary advanced asthma care clinic. We've kind of kept the low profile. The patient population that we've targeted, I guess, are patients with high healthcare utilization. So patients who go to the ER or need to be hospitalized in the last year, or who have a high burden of systemic corticosteroid use. This is a multidisciplinary clinic, so Samir and I started it. Ravi has taken over. Now, primarily, Mary Love Patton is involved as well, and we're really tremendously helped by the primary care pharmacy team and the pulmonary clinic staff with the nurses and respiratory therapists. So what are the FDA-approved options for severe asthma? I won't run through all the MABs. They get a little bit confusing in terms of the pronunciations. But there's lots of options here. And there's also a procedure called thermoplasty, and then tiotropium is on this list. The primary point of this table is more a compare-contrast. Some of them have biomarkers that you need to demonstrate to their insurance company to get qualification for. Some don't. Thermoplasty doesn't, tiotropium doesn't have a qualifying biomarker. A few have predictive biomarkers, meaning if you have a high level of X, your likelihood of response to this drug is good. But most don't, and even with high eosinophils or high nitric oxide, the response rate is about 50%. The costs are radically different. So the biologics, are the most costly. Thermoplasty is cheaper than biologics, and tiotropium obviously is the cheapest. But they each have, risks and benefits. And tiotropium is another inhaler, and some patients, say the burden of these inhalers is high. So what do we know about asthma phenotypes? We all know that there's this clinical triad of wheezing, chest tightness, shortness of breath, and reversible airflow obstruction. The dominant phenotype is what's called T2 high, so the allergic pathways that are driven by interleukin 4, 5, and 13 primarily. You might have a history of allergic disorders. An early age of onset would be classic, driven by eosinophils, and most patients are corticosteroid responsive. And this probably represents about 80% of patients with asthma. Well treated by inhaled corticosteroids. There are alternate strategies including a leukotriene receptor antagonist or a long-acting beta-2 agonist. And if you have more severe disease, there's lots of biologics now targeting IgE, IL-5, or the IL-4/13 receptor family. Again, there's only about a 50% response rate, meaning half of the patients don't respond, and these strategies are costly. What about the other half of this figure in the T2, what's called the T2 low spectrum? Often these patients have a later age of onset. They have neutrophils as the predominant granulocyte, or there's some that may not have granulocytes at all. There may be smoking-related diseases, there's obesity, and they have a propensity for severe asthma. We don't have a lot of treatments on this side. So represents probably 20% of all asthmatics. There's one trial in mild patients that suggests they may preferentially respond to tiotropium, although that needs to be studied further before it can be recommended. And in the severe asthma category, we really only have thermoplasty. We don't have any drugs in this category. That represents probably 50 to 70% of patients with severe asthma. So severe asthma has an increased prevalence of steroid resistance, and I'll show you a little bit of data about that. We studied this in the Severe Asthma Research Program, which is a nationwide cohort, 7 clinical centers, 715 patients or so. At the baseline evaluation, we gave all of these patients an injection with triamcinolone acetonide, or Kenalog, that's formulated to last about 3 weeks in their system. And we brought them back 3 weeks later and did profiling again of all of their lung functions and nitric oxide, eosinophils, and biomarkers. And this is the change in their FEV1 over the 3 weeks. So some people got better, some people actually got worse. And these histograms are a proportion of patients. So the adults are on top, the kids are below. Blue would be the folks with non-severe asthma, red would be those with severe. And you can see the histogram is shifted to the left here in the relatively resistant, with the definition of response of improving your FEV1 by 5%, an absolute difference. Sorry about this. So we asked the question, does this evoke phenotype predict the loss of lung function over time? We followed this cohort for the next 4 years and assessed the change in their lung function over a 4-year period. And you can see there's a wide range. So half the population has an improvement over time, and about half the population has a decline in lung function. The different colors are categories. So with the figures over here, so the most severe declines have loss of 8% predicted over 4 years, so 2% a year, or 4% predicted over 4 years. That change in lung function at baseline by steroids has a profound predictive value in terms of who's going to improve versus who's going to decline. The history of exacerbations, surprisingly, is not that powerful a predictor. And we did the multivariable modeling, and the steroid response for each 5% decline in this, what's called the TD-FEV1, there's a 50% increase in the likelihood of ending up in this severe decline category. And that's adjusted for exacerbations, lung function, obesity, and blood eosinophils. So severe asthma also has frequent exacerbations. I'll show you a lot of data with that. Oh, goodness. my vocal cord dysfunction. There we go. So I'll show you a lot of data about frequent exacerbations and a little bit of data about emerging phenotypes related to oxidant stress and microbiome signatures. So the baseline data from this severe asthma cohort, again, 715 individuals, 60% of them had severe disease for our recruitment goals. 25% were recruited in the childhood age range. 40% of patients had no exacerbations in the prior year coming in, and 25% of the population were asthma prone, exacerbation prone, with at least 3 exacerbations in the last year. And a few things were surprising. So the reversibility to bronchodilators had a big predictive value in terms of identifying or associating with how many exacerbations they had in the last year, and that was significant for both adults and children. What surprised us is the relationship with blood eosinophils was relatively flat. Just a trend for adults and not significant at all for the kids. And we all love eosinophils. There's the statue in the Wimmer of the eosinophil. How can this be? Well, fortunately, the multivariable model enriched the strength of this signal. So blood eosinophils do have a profound impact on exacerbations in the longitudinal cohort as well as the replication data set. Comorbid conditions like sinusitis and reflux have a big impact, and BMI also has a big impact on exacerbations. The bronchodilator reversibility lost significance here, and it was just a trend in the replication cohort. So the interesting thing, this is an observational study, and the rate of exacerbations declined by 50% just by being in the study. So as we watched these patients over time, they got a little bit better. So now at year 1, 60% of the patients have 0 exacerbations, and the proportion with lots of exacerbations went down as well. This is what's called a Sankey plot, so you can follow patients over time in what I call the chutes and ladders. And the important thing here is that 41% of the patients were exacerbation-free for the full 3 years of follow-up here, and 21% continued to have at least 1 exacerbation every single year, are truly exacerbation-prone. Clinical history is the most powerful predictor of whether you're going to have exacerbations up front. This is what's called a transition state model. So if you look at the year 3 data, and did you have an exacerbation in year 3, yes or no? If you don't look at any of the clinical data or the clinical history, you have a 40% likelihood of having an exacerbation in year 3. If you look 1 year back at year 2, your predictive power goes up to 60%. If you have 2 years of clinical history, look at this. Your ability to predict exacerbations next year is 85%. Similarly, if you have 2 years of data exacerbation-free, that predictive power goes way down. In terms of the likelihood of an exacerbation. So clinical history is really important. So what about some of these emerging phenotypes? Oxidant stress happens due to a lot of environmental agents, tobacco smoke, pollution, and this is a measure of oxidant stress. It can be very high during exacerbations. It declines in most patients after discharge, and in some patients it starts to creep up again even at follow-up visits. It's a very complex biochemistry. There's lots of radicals here. One of the pathways to protect against this is S-nitrosyl glutathione, which happens to be down in patients with severe asthma, and that's driven by genotypes, leading to increased smooth muscle contraction and more inflammation. Looking to the future, we found a drug called cavasonstat that we'll be testing in PRECISE, which I'll tell you about in a little bit, that blocks this pathway and increases S-nitrosyl glutathione and reduces airway inflammation. We'll be testing whether that works in severe asthma. Another emerging phenotype in exacerbation-prone patients may be their microbiome signature. So this is a fascinating study enrolling exacerbation-prone patients who had asthma or COPD, and they did what's called a principal components analysis to figure out what were the factors that discriminated between asthma and COPD in exacerbation-prone patients, and they couldn't find any. If you look at the triangles and the circles here, there's some of these patients in all of these areas here. And really what discriminated these groups was their microbiome signature, a ratio of Proteobacter to Firmicutes, which is the main thing. And that is associated with the types of granulocytes or the types of triggers that lead to their exacerbations. Why do I bring this up? Well, one of the drugs that we'll be using in the PRECISE trial is called Bronchovaxum. It's a lyophilate of lots of different types of bacteria. It's been marketed in Europe and other parts of the world for decades to treat upper respiratory tract infections, and it's thought to boost antiviral responses. So severe asthma also has a few other emerging phenotypes that are more than just the simple T2 allergic story. So I'll tell you about metabolic dysfunction in a little bit more detail. There's a T2 ultra-high phenotype with mucus plugs, and there's a mast cell dominant phenotype. So many of our patients with asthma have obesity, and some of them also have the metabolic syndrome with diabetes, hypertension, hyperlipidemia. So there's this concept that the visceral fat is driving inflammation, primarily by IL-6, and that may actually lead to smooth muscle proliferation or mast cell hypertrophy and an asthma phenotype. There's also data to suggest that patients with asthma, and especially severe asthma, downregulate a lot of the enzymes in the Krebs cycle. And I won't quiz you about this at the end, but but the interesting thing is that that's linked to nitric oxide production and airway inflammation. And so I bring this up because we'll be testing a drug called clazakizumab that neutralizes IL-6, and we'll be testing medium chain triglycerides as a way to make your mitochondria more efficient again and reduce inflammation. Here's a little bit of data for the IL-6. So this is, again, within the Severe Asthma Research Program. Patients with high levels of IL-6 have lower lung function, whether they're lean or obese, and they have more exacerbations, again, whether they're lean or obese. And in the predictive model for exacerbations, IL-6 is a risk factor for having more exacerbations, even after adjusting for age, BMI, and blood eosinophils. So what about the T2 ultra-high endotype with mucus plugs? So I'm going to show you a CT scan of a patient of mine, mid-50s or so, adult onset asthma, no allergies, lots of nasal polyps, presented to the ER with shortness of breath. And this was his contrast CT scan. So you can see the contrast not only in his ventricles, but also in his pulmonary arteries. And the gray things here have the density, that's like this. Those are their airways, his airways. And they're gray because they're filled with mucus. So every single segment in his lower lobes is just plugged up with mucus. And if you go back 9 years in him, some of these were there at that time too. So the biochemistry behind this involves elevations of both interleukin-13 and IL-13, IL-13 and IL-5. IL-13 drives goblet cell production and mucus production, and the IL-5 drives the production of eosinophils and eosinophil peroxidase. The biochemistry leads to cross-linking of this mucus, and you get these really sticky mucus plugs. I highlight this because we'll be using a drug in PRECISE called infiциtinib, which blocks these receptors downstream to see if we can target patients with the ultra-high phenotype. There's a little bit more complexity here related to mucus production, and it's simple carbohydrate biochemistry, like blood group antigens. So if you have the O blood group plus this Lewis B secretor phenotype, and you stain for polysaccharides, this secretor phenotype looks very different in the airway biopsies compared to the non-secretor phenotype. And it has an independent odds ratio association for exacerbation proneness in the San Francisco cohort led by John Fahey. So what about the mast cell dominant phenotype? So Mast cells are resident in the airways and smooth muscles, and these are some staining for tryptase and chymase, which are two markers picking up mast cells. They get into the smooth muscle, and they're associated with airway hyperresponsiveness. Patients with severe asthma have more mast cells than non-severe. They're relatively resistant to corticosteroids compared to eosinophils. And these cells are critically dependent on what's called stem cell factor, or KIT. It's a tyrosine kinase for their survival. So KIT, interestingly, is also targeted by imatinib, or Gleevec, which is primarily targeting ABL for CML. But it also hits KIT, and this is a proof of concept study that we were involved with, led by Elliot Israel at the Brigham. And small study, 6-month trial, patients who were randomized to imatinib had a fall in their plasma level of tryptase, whereas the placebo group did not. So we knew we used the right dose, and we were hitting our pharmacodynamic target. These patients also had an improvement in their PC20 and a small change that was significant in their FEV1, as well as airway wall thickness was better on CT imaging. Responders in this group here were more likely to have neutrophils in their lavage before and after. And interestingly, they were in the low eosinophil population. So this is predicting good response in patients who were assigned to imatinib. So to summarize what the characteristics of severe asthma, there's an increased prevalence of corticosteroid resistance, there's frequent exacerbations, and there's lots of new phenotypes that are evolving beyond the traditional T2 allergic paradigm. So that leads me to the concept of precision medicine. So what is precision medicine? So this is a review article by a consortium involved in these types of adaptive trial designs. And it's, captured, this spirit is captured by the right drug, the right patient, the right time, now. So using tests that are available in the clinic to figure out which drug is going to be best for this patient. It's guided by biomarkers that are available in the clinic. And the hard part of developing this is that traditional clinical trials design are not terribly efficient at doing that. And so we had to, as a group, think about ways in which we could make these trial designs more efficient. So this is what is, in the asthma group, affectionately known as the confusogram, because there's arrows going everywhere, and lots of molecules here. The ones in yellow have been used in clinical trials. There's a lot more on the T2 side of this diagram. There's fewer on the non-T2 side. And as I mentioned previously, none of these have been approved for disease. So if we wanted to design a trial, well, you could just pull out this article and pick one of these molecules and say, aha, we've got a drug for this, and let's just go to the races and try to enroll these patients. That's harder to do than you might think, and we have some experience with this. So mepolizumab is a blockbuster drug for patients with high eosinophil asthma. It's easy to use. The really interesting thing about these trials is that the first 3 were completely negative for all clinical endpoints. And the key thing is that they just openly enrolled everyone with severe asthma. They didn't really stratify or enrich based on biomarkers. So the pivotal thing that resurrected this drug was they started enrolling patients with high eosinophils and with prior exacerbations. So they really had to screen a lot of patients and turn away more to get the right patient population to study. Other examples, so lebrikizumab, it targets IL-13, used a stratified design based on their type 2 status with a composite biomarker of IgE, blood eosinophils, and periostin. Unfortunately, they had some assay performance issues with periostin. They also had some production issues with IL-13, and that led to trials that didn't work out so well. And then a third example is a compound called brodalumab, and that targets IL-17. This trial relied on post hoc subsets of T2 subsets, didn't have an enrichment strategy. And how did these turn out? Well, we know that mepolizumab now is clinically useful, so that succeeded. Unfortunately, the other two programs, not just trials, but programs, failed. So we're talking about 4 or 5 trials before this started to take off. Probably 3 or 4 trials before this one failed, and at least 2 trials before this. So we're talking about a lot of patients and a lot of money, and could we do this a little bit more efficiently? So there's this concept that I'll introduce now called a master protocol, and this is a New England Journal of Medicine review article by Woodcock and Lavange. Lisa Lavange is a co-investigator at the Data Coordinating Center for our trial design. And the concept here is you can have one protocol and test lots of different drugs and be a lot more efficient in your recruiting strategies to have an option available for every patient. The classic example here is the I-SPY trials for breast cancer. And I believe Mark Burkhardt may have highlighted those a month or 2 ago. So if you continue to screen your population and have different options for patients who have different biomarkers, the concept with this master protocol is that you can have different drugs and they may succeed or fail, but you can change the mix as you go, and the protocol marches on. So you have a lot of efficiency with the IRB and all the infrastructure for your trial. You can also use this to develop new biomarkers. So this group down here is biomarker negative at the start, but if you identify a new biomarker at the end, you can start move patients in. So how does this work from a conceptual standpoint? So you're learning as you go. You enroll patients, you randomize them, you record their outcome, you have some sort of interim analysis, you update your data set, and you do a lot of modeling. There's a lot of computer time here. And you have a set of rules for termination if things are working or if things are failing, and then you adjust your randomization probabilities and you keep going. If drugs are working, you graduate them, and you can also introduce new drugs into this concept. So this uses a concept called response-adaptive randomization, which is the math that I got really excited about, and Bill was like, make sure you tell a story when I was writing the grant. But I did find a cartoon to kind of explain this. Think about this master protocol and different snapshots in time, and each one of these cartoons will be a different snapshot in time. So at time period 1, you're just starting out, and you're randomizing for this row of patients here relatively equally, so a 2-to-1 randomization intervention versus placebo. And you have no real information about whether things are succeeding yet or failing because it's fairly early in the trial. So you get some data with these patients that are enrolled, and it looks like drug 1 is starting to fail. It's not quite significant. It hasn't reached that red line here. So you use that information to play the winners. So you want to feed more patients into 2 and 3 because they're doing better than 1. And so in this next row of randomization, there's fewer patients assigned to 1 and more patients assigned to 2 and 3 because it's looking like that drug is going to work. So at the next snapshot, drug 1 now has had a few more patients, and it's clearly past this red line, so this drug is now out. So you really restrict randomization there until you are confident that that's out, and you promote the winners again. And you can use this ongoing, and if a drug increases or passes this green line, it's successful and it can move on to a traditional phase 3 type of a design. So again, this is interim analysis and a review of your randomization probabilities and refinement. So the NHLBI convened a clinical trial network called PRECISE, which stands for Precision Intervention for Severe or Exacerbation-Prone Asthma. And the RFA required early phase 2 proof of concept studies that were novel and were targeted for biomarker-defined subgroups. Adaptive design was encouraged to increase the trial efficiency, and we also were really encouraged to explore novel biomarkers so that we could refine those subsets. So we got going around Halloween of 2017. I'm proud to say that the IND was approved on the first pass for the first 2 drugs, and the IRB was approved on the first pass just about a week ago. So we're getting ready to launch. There's 32 performance sites around the country. The primary objectives are listed here. So we want to identify drugs that work in biomarker-defined subsets. And a co-primary objective here is that we're going to adaptively refine these definitions to optimize the subgroups that we're targeting for treatment. As you'd guess, we're going to use a master protocol, and we've got 3 primary outcomes here. FEV1, asthma control with this ACQ questionnaire, and exacerbations assessed by a novel tool called the COMPEX. So the basics about entry criteria, we're enrolling adolescents and adults. You have to have at least medium dose of inhaled corticosteroids plus a second controller, stable therapy for 2 months. You have to have your asthma verified by reversibility or methacholine responsiveness, and you have to have an element of risk, either poor control, low FEV1, or exacerbations. So folks that get excluded are those who are on high doses of prednisone every day, who have other lung diseases, who have a robust smoking history, who've been on a trial. And then some of these drugs will have safety risks, and so we're using intervention-specific exclusions to make sure that you don't get randomized to the drug that you're likely to have problems with. You can still get randomized to some of the other drugs in the portfolio. So here's a simple schematic for how the trial is going to work. And unique features, we're again going to use prospective phenotyping. Every patient will get an active drug. There'll be a futility analysis, and patients can try more than one drug. So we screen these folks at baseline. We do a lot of biomarker assessment. We randomize them with a 2-to-1 ratio of biomarker positive to biomarker negative in each of these arms. And then we randomize them again to receiving placebo first or treatment first, that sequence. So for every treatment period, there's 16 weeks of treatment, and then there's a washout phase, and then you go on to another 16 weeks of treatment, the opposite of what you got in the first period, and then you go to washout. After that, if you want to continue, you can go on to period 3 or period 4, get re-randomized again to a different intervention, 16 weeks of treatment, 8 weeks of washout, and then come back if you choose. So how does this all work from a placebo standpoint? Because we have pills, we have injections, we have a dietary supplement in the mix. And so the first 2 periods are critical. So each patient gets an active drug, each patient serves as their own placebo control. And that mode of delivery is matched. Once you graduate into period 3 or 4 or 5, your chances of getting placebo go down. We're borrowing from placebo data from these early phases. And you get to experience more than one drug. So every patient gets an active drug, and the longer you stay in, the more likely you'll get one that's personalized for you. So how does the refinement of the subset definitions work? So the predictive biomarkers that we're using up front are pretty simple. So blood eosinophils, exhaled nitric oxide, both of which we can do in the clinic. IL-6 levels, which will be done at a PPD, and genotyping, which will also be done, I believe, at PPD. But the interesting thing is, when we were planning this trial, we surveyed the principal investigators in the room, and there was a wide range in confidence of whether these biomarkers predicted a good response. Some, has high level of confidence, and other biomarkers we weren't so confident in. And so we're going to have a lot of exploratory predictive biomarkers with a lot of different sample matrices: plasma, sputum, chest imaging with a CT scan, urine, nasal swabs, and PBMCs. As I mentioned, we're going to refine these definitions using up to an additional 4 biomarkers. So how will this work? So the example that I show is with imatinib, and the responder analysis suggested that the low eosinophil group might have a greater likelihood of responding to imatinib. The primary predictive biomarker is low blood eosinophils. We'll randomize 90 patients. 60 of these will have the biomarker positive signature with the low eosinophils. 30 patients will have high eosinophils. We'll do a futility analysis at 90, and if it does not show futility and we want to continue, there'll be 2 rounds of enrollment with modified definitions. Each time we'll add another 45 patients. So how might that look? So to get in as a biomarker positive after this round of enrollment, so you might have low blood eosinophils plus really thick airway walls on your chest CT. Or maybe the second round you have higher blood eosinophils, but we know your tryptase level in the sputum is really high. So we're becoming a little bit more sophisticated than just this low blood eosinophil group. So the final analysis will have 150 patients in the biomarker positive group for efficacy and 50 patients in the biomarker negative group. So to summarize, the GINA guidelines, and this is for the whole talk, the GINA guidelines recommend symptom-driven use of inhaled corticosteroids in patients for mild disease. I highlight that in orange here because this is still off-label in the US. It does take some coaching. And make sure that you avoid salmeterol. You cannot use salmeterol for this strategy. Only 10% of patients have severe disease, but they have the vast majority of the burden and the risk. 30 to 50% of patients with severe asthma are eligible for FDA-approved biologics. Unfortunately, the response rate to these is not as high as we would like, and there still remains several unmet needs, including what to do with patients with T2 low asthma. So PRECISE is the name of the clinical trial that we'll be using. We'll be starting soon. We're going to use state-of-the-art methods to refine these definitions and a master protocol to test multiple new drugs. So thank you for your attention. This comes with a huge team effort. So the PRECISE center that we are partnered with is at the University of Illinois in Chicago. My co-investigators are Dr. Jarjur, Dr. Jackson. Ron Sorkness is a pharmacist and respiratory physiologist who runs our spirometry core. We've imaging colleagues, Sean Fain, Mark Schiebler, a fantastic group of coordinators. So Julia Bach, Lori Wallet, Danica Klaus, Evelyn Falabine, regulatory support and grant support from Tina Pallas, Gina Krisafi. Paige Lowell and Rick Kelly are helping with spirometry support, and Paige is a coordinator. Lab support from Heather and Andrew and Arthur, and then our partners at UIC. And Bill Busee and Chris Sorkness were huge in terms of writing this grant and providing the infrastructure to make us succeed. Shout out to the Advanced Asthma Care Clinic. Samir and Ravi have been fantastic colleagues, and Mary, the primary care pharmacy team, Ann Locken in the pulmonary clinic, and then the other staff, both at the West Clinic and the pulmonary clinic. And with that, I will also acknowledge my funding. NHLBI has been fantastic for me, so thank you. And thank you. So.
Thank you very much, Loren, for an outstanding presentation. We can take some questions, and go ahead. And Loren, please repeat the question after you hear them.
Please.
I can think of reasons why it might not work, but is there any benefit in trying to reduce some of these biologics inhalation?
Yeah. Could you use a biologic strategy by inhalation? I actually think there are a few companies that are trying this. So it's not a crazy idea. It might not be the traditional antibody, but there are small marker or small molecule drugs that some of the companies are exploring to be delivered by the inhaled route. Yeah.
Loren, wonderful presentation.
Thank you.
It really, I think, highlights the complexity of asthma. In this regard, we rely a lot on inhaled corticosteroids.
Mm-hmm.
And if you look at the efficacy, it's highly variable. The question is, how aggressive should we be in general in phenotyping every patient with asthma?
Yeah, great question. So what Dr. Busee is pointing out is that the response to inhaled corticosteroids is very variable. And should we be biomarking earlier in the spectrum of severity? I think the Sienna trial from the AsthmaNet really highlights that concept is fair game. So if patients do not have high sputum eosinophils, their response to inhaled corticosteroids in that trial was very low. And what I understand in some ongoing analysis that's not yet published is that the blood eosinophils may have been the best biomarker that is readily available in clinic. So if you have high blood eosinophils, then you, and this comes from multiple other studies too, high blood eosinophils predicts greater responsiveness to inhaled corticosteroids. But if you have low blood eosinophils, you may not be terribly responsive, and we don't have great options yet for that population. So, yeah, in the back.
Great talk. It's really exciting to see how we can move precision medicine to asthma in our patients in the clinic, especially the ones that are challenging to treat. In this study design, it seems like there's a lot of different statistical testing that's going on. Can you talk a little bit about the balance between true discovery in terms of discovering novel, important biomarkers, but also false discovery, and leading to, again, some future trials that could be negative because of the testing?
Yeah, so that gets into the math. The type 1 and type 2 error rates are something that the statisticians have exquisite control over. It is a proof of concept study as well. So we wouldn't be able to use any of these results to go to the FDA and say, aha, imatinib or any of the other drugs is ready to be approved. It would need to be confirmed in a traditional phase 3 design. But the type 1 and type 2 error rates are something that the statisticians are very focused on and control during the course of the trial.
Loren, a quick question about the patients who are going to be in the study. How are we going to deal with patients who are already on biologic, trying to try them on those drugs?
Yeah, that was something that we argued about extensively, and we will allow patients on biologic therapy into the trial, assuming that you continue to have risk. So if you're on a biologic and you still have symptoms, or if you still have low lung function, or if you still have exacerbations even after starting the biologic, you are not excluded from the trial as a patient. And you can continue your biologic during the study, and yeah.
So in the old days, we were taught to look for eosinophils in the sputum. Does that make any sense?
There's, so can we use sputum eosinophils in the clinic? And because it is used for a lot of clinical research studies and clinical trials. Unfortunately, it hasn't really caught on in the U.S. In terms of teaching a clinical lab to be good at it. It's a challenging sample to manage. It's really stick and gooey, and our lab personnel are really skilled at handling it, but it's not something that's high throughput yet for the clinic.
If no other question, I just thank you very, very much, and wonderful talk, Dr. Denlinger.